Hello, my name is Thomas Pereno, and I'm going to discuss with you waveform analysis. The waveforms I'm going to focus on are called scalars because they plot something versus time. We will discuss volume versus time, flow versus time, and pressure versus time. Let's first look at volume assist control. This is a patient with normal lung conditions. Let's take a closer look at the waveform. With volume assist control, it is very common to have a constant flow pattern. This is why it's straight. When something doesn't change over time, it's flat. So here we have constant flow being delivered. Once the tidal volume is reached, the breath is technically supposed to be terminated. However, we've added a 0.2 second pause, as you can see here. So when it reaches the volume, it's actually held in the lungs and there is no flow. The breath is held, so flow is 0. And because of that, we have this volume being held in the lung, and because there is no flow, we have this plateau pressure, which represents the pressure in the alveoli when the breath is held. This pressure here is due to the resistance in the airways when flow is constant. Now let's look at pressure assist control. With pressure assist control, the pressure is held constant over time. So the flow increases rapidly to reach the pressure, and then it slows down to maintain the pressure. If it continued at the same speed, this would be like volume assist control and the pressure would continue to rise. Instead, it slows down over time to maintain this pressure. The speed at which it reaches the pressure is called the rise time, so it's how fast this flow increases. And right now, the rise time is in seconds and it's 0.01, so it's a very rapid increase to the pressure. If we increase this time, let's say to 0.1 second, and let's start the waveforms again, you'll see it's a much more gradual increase to the peak, as you can see here. Sometimes this will eliminate some overshoot that occurs with pressure control and pressure support. For now, let's keep it like this. Sometimes pressure assist control is thought to be a plateau pressure that is read. However, keep in mind that unless flow reaches 0, it's not the true plateau pressure. So here you can see flow is not reaching 0. So although it's close to 0, it's not quite representing the plateau. In order to do a plateau, you would have to add an inspiratory pause, and this pressure would be slightly higher than the plateau pressure on a patient that is passive. Let's see. As you can see, the plateau pressure is 12.9, and the peak pressure here is 15. So when flow reaches 0, the pressure in the system drops. So some of this is due to resistance. When patients begin interacting with the ventilator, it makes sense that it would cause changes to the ventilator waveforms. However, their effort is most likely going to alter the parameter that is not controlled. So in volume assist control, the flow is controlled. Therefore, effort will not cause changes to that waveform. It will more likely cause changes to the pressure because the pressure is not controlled. In pressure assist control and pressure support, patient effort is less likely to change the pressure parameter because pressure is controlled and targeted. Therefore, it will change the flow waveform. This is very important for understanding how to assess the patient's interaction with the ventilator at the bedside. When assessing waveforms at the bedside, it's extremely important to understand the term asynchrony. It can refer to a number of specific types of ventilator patterns with the waveforms. However, it's a general understanding that it's a difference between the neurological timing of the patient's respiratory drive and the ventilator timing. It's basically out of sync. So it's either the ventilator cycling off too late or too early compared to what the patient wants. Another form of asynchrony or dysynchrony is the ventilator does not meet the demand of the patient, and the patient can get what's called flow starvation. This typically happens in something like volume assist control when the patient has high drive, which I'll describe in just a moment. Another form is when the patient is unable to meet the trigger criteria for various reasons. This typically can happen when the cycling of the ventilator is delayed, so it is prolonged, and when the patient goes to take another breath, they still have a lot of volume and pressure in the system, meaning their respiratory system, and they are unable to trigger the ventilator, either due to extreme weakness of respiratory muscles or simply because they are just dynamically hyperinflated. Let's first look at volume assist control. I've introduced patient effort into the system. It's represented by this pink line. Every time there's an effort, it decreases. This would represent the pleural pressure or the PMUS that's being generated by the patient. And as you can see, the flow has no indication of effort because flow is held constant. Where you see the patient effort is in the pressure waveform because it is not controlled. So you see a scooping that is consistent with the patient effort. The patient's effort can be measured on the ventilator using the occlusion pressure, P0.1. In this example, it is 2.35, which is considered normal. This effort is not excessive. Now let's look at excessive effort. Now the P0.1 is 4.70. This is considered high. And you can see there's much more scooping of the pressure waveform. Again, no indication in the flow. Now some ventilators may allow the patient to pull some flow, but in general, if it's not allowing it, it should not change. And what you should see is a scooping in the pressure, which you can see is much more drastic than it was in the previous example. This is considered excessive effort. We are hearing reports that patients with COVID-19 have excessive efforts when they begin to interact with the ventilator. So one parameter that can be easy to look at is not only the occlusion pressure, which is available on every ventilator, but also pay close attention to what parameter would be changing on the ventilator screen. Now let's look at pressure assist control. Here we have the normal drive again. The P0.1 is 2.35. What you can notice is that the patient makes the effort, and when they're done, you actually notice a change in the flow waveform. Again, you should not see any obvious change in the pressure because this is what's controlled in this mode. So when you see effort, you should see a change in the flow because it's not controlled. Now the flow is a little bit more rounded up here than normal. Typically it has a peak and then it decelerates immediately. So it's a bit rounded. So that's one indication that the patient is making an effort. But then the second indication is here. When the patient basically ends inspiration into passive exhalation, you can see there's a change in shape here. Now the criteria for cycling off this breath, if you recall in pressure assist control, is time. 0.8 seconds is what is set. So the breath goes on to 0.8 seconds, but the patient has actually stopped breathing here. So this is a perfect example of the mismatch between the patient's neurological time and the ventilator time. So of course, one way we can address this is we can change the time. Now you can see the breath cycles off much more closely to the patient's effort. This is one way to optimize a ventilator mode. When you see changes in the flow, for example, in pressure assist control, you can try to address this by shortening the time so that it does not have this shape here. Now let's look at high effort. Now the P0.1 is 4.7. There's not much changing here except the flow has become more rounded at its peak. There's much less of an obvious peak to the flow and the deceleration is normal. However, everything seems more rounded. This means the patient is doing more work. You don't see an obvious spike in the flow. It's much more rounded. However, the timing is enough to know that it cycles off and then into exhalation, but there's no delay in cycling off here. Now let's look at pressure support. With pressure support, there is no inspiratory time in seconds that is set. If you recall from the basic ventilator settings video, it's a cycle off percent, so it's 25% of this peak flow is when the breath cycles off. And in this patient example, it's actually relatively in sync with the patient's neurological drive. Now, this is not always the case, and often this requires adjusting, specifically in patients with high airway resistance, which I will talk about in just a moment. But as you can see, the drive is normal, 2.35 of a P0.1 measurement. Now let's look at the patient with a high drive. Now the P0.1 has gone back up,